very fascinating case which has got a very much relevance in clinical practice, because generally what we say is that we often will talk about physiology and pathology, and often certain scenarios in pediatric endocrinology will be such which will be a marker of a serious disease which may often be missed with disastrous consequences. So we'll talk about a common presentation with an uncommon cause in which there were a lot of issues. It's part of our Grand On series which we do every month, and you all can have a look at our website learning.rosociety.in, which has got a lot of information about pediatric endocrinology. We've got various courses which are available, including a comprehensive fellowship and a diploma course. There are a lot of programs going on in terms of the journal clubs, in terms of the lecture series that we have, and the publications and mobile applications which are available. So today we're going to focus about a very interesting case of a delayed puberty, which really emphasizes how a common condition, a pediatric endocrine condition, can have huge implications in terms of the outcome.
Yes, sir. Good afternoon, everybody. So we recently had a 16-year-old girl in the office who had visited a pediatrician for complaints of delayed puberty. She also had all of mild to moderate executive worry, but she had no vomiting, no visual symptoms, and no incontinence. On examination, her weight and height was appropriate for age. The SMR was B2B1. Initial workup.
So just hold on from there. So now, if you talk about a 16-year-old girl who has come to you with delayed puberty, what are the key 1, 2, 3 possibilities you will think? What is the most likely cause in this scenario?
Delayed puberty is rare in girls. In boys, it may be physiological, but delayed puberty is just rare in girls. So we will like to think of in lines of.
So, if you forget about this particular age or other demographics, if I just say, what about delayed puberty in girls? What are the various proportion of cases you will think of in terms of etiology? So how many cases you think? How percentage wise? So 35 to 40% will actually be CDGP. Then you will have a group like 20%, 30% will actually be something like Turner syndrome. So hypergonadotropic hypogonadism. Then 15-20% will be systemic illness, and 15% roughly will be hypergonadotropic hypogonadism. So still the leading cause will be CDGP. In boys, the chance will be double. So it will be like 60-70%. Now, what I'm trying to say is that what are the pointers? So when you are evaluating such a child, you want to know when I am not dealing with CDGP. So what will be the pointers that will point, okay, this girl doesn't look like CDGP.
So your growth was appropriate for it. So her height and weight were not
yes.
compromised.
So her height was normal for age. Second scenario that you were saying is that the age is a bit more. So 16 years in girls is pretty advanced. So it will be a bit later presentation. What about what else?
In favor of CDGP.
Again CDGP.
Again CDGP is again headache.
So headache is a phenomenon which we will ask about. The breast development, generally they don't have any breast development at all. So it may be that she is CDGP and now she is entering puberty. That is why she has breast stage 2 development. But then that is a possibility. So what are favoring CDGP in this scenario?
B2B1 is definitely.
So there is no pubic hair development, which is also effective. So that will be the thing that you have to worry about. So this looks, I would be very wary about labeling this girl as CDGP in this scenario because she is reasonably tall. And then you will ask about the specific other complaints. Any family history of delay was not there in this case. So again, these are the red herrings that you're dealing with, something beyond just CDGP. So now when you go beyond CDGP, of course, you are mainly concerned about a lot of hypergonadotropic hypogonadism. So what are the features of hypergonadotropic hypogonadism that you will get on examination or history?
The hypergonadotropic hypogonadism will be tunnel will be there. So short stature, anthropometry will be.
So short stature, typical, all the facial features, skeletal features. So that you will be there. So that was obviously not there in this case. This girl was a normal built, normal statured child. So that becomes unlikely. Of course, you can have some other forms of gonadal dysgenesis which may not have that much abnormalities which are there. Do you think this could be a systemic illness scenario, Vibha?
So in the systemic illness, first of all, as she said, the weight was appropriate for that.
So you will expect the height and weight to be affected. The child will be more sick in that scenario. So a non-sick child who is not short always think of something which may be sinister in that perspective. Now, you've got breast stage 2. Will you call it a stalled puberty or will you call it a delayed puberty to begin with? What did the parents tell you?
They said that no development has.
So no development. So maybe it is both ways. There was some initial development and then it stopped. So it's difficult to say, but if you get a clear-cut feature of stalled puberty, then you are really worried about certain causes. So what are the conditions which are excluded by a stalled puberty?
If it was CDGP, it would not have a.
So CDGP will never have a stalled puberty. What else do you think, Manoj, if you have a stalled puberty rather than a complete absence of puberty? So what I'm asking to you is that what are the causes in which there is no development at all?
So congenital hypogonadotropic hypogonadism is out.
Congenital HH also. Okay, so if there is a, unless you say it's a mildish form in which you can have some development, so there is a spectrum. But the severe forms of MPHDs are typically lost, but they are anyway less likely because of the height and weight. Then you said congenital HH, yes, so plus minus anything else.
Severe form of Turner syndrome.
So Turner syndrome, I would not say anything on that. B2, I wouldn't be worried about. Turner syndrome, pretty much we can have that.
Systemic illness is the.
Not really, because how much it is affected. So I would say the other thing which will be out will be something like aromatase deficiency, estrogen receptor defect, something which are very, very severe, like in which you have zero function. So that will be out in that regard. So definitely you have got some breast development, means that whatever the illness is not completely knocking off the system. There is some scope of growth there. The other big thing is that if it is stalled puberty, the first thing I will think about is the acquired lesion that you have to be really bothered about. And as I always say, that although most children with delayed puberty may not have a pathology, it may be a marker of a sinister pathology which happened in this case. Now let's go on to the workup.
So initial screening for systemic illness was in the normal range. PSH was in the normal range and prolactin level was normal. FSH was not high and LH was definitely in the puberty, had come into the pubertal range.
Do we have an estrogen level as well? So what we are seeing here is that there is a decreased amount of LH and FSH, but whether it is really low, it's not in the zero range. So if you talk about Calamin and many of those GnRH receptor defects or the defects of FGF receptor or charge, all those scenarios, the levels are much, much lower. So this maybe somebody might say, okay, this girl has now just entered puberty, LH is slightly high, so let's wait and watch. This could be a problem which may happen in this scenario. Okay, why was a karyotype done? So I think that is another big message, that nobody should do a karyotype unless you have got a documented hypergonadotropic hypogonadism. Unless you have done that, why unnecessarily do karyotype in the beginning in this phase? And this is very common scenario. So this is clearly a hypo scenario.
Somehow for delayed puberty, hypoplastic uterus with non-vagina.
So at least they showed a hypoplastic uterus. Often you will get a report of no uterus. So this is of no concern. So as we say, if there is no breast, no uterus, don't get an ultrasound done also. So that is of no consequence per se. And ovary and all, unless you are doing a transvaginal, it's very, very difficult. So I don't give much importance to a pelvic imaging at this stage. So now if we look at this picture, Manoj, what do you think? Do you think this could be CDGP which is improving? Theoretically, yes.
Yes.
Theoretically,
LH-FSH is not that much low. So
yeah, so now it's picking up. B2 has also happened. So this can be a tricky scenario in which you can say, okay, let's wait and watch. This could be a general sort of a dictum. However, the finding of headache. So did you get the headache primary on, were they having this complaint of headache, or was it a retrospective finding?
It was definitely a retrospective finding. It was something that we found on probing whether she had. So she said yes or no, she had.
So that's a difficult scenario. But I think this brings us to a very, very important thing, that if somebody is 16 years, so that's what we have to think in a holistic picture. Otherwise, if you look at it, any approach, it will say, okay, this is like a CDGP / a hypo. But neurological features, so they have to be very cautious about etiology of neurological features, which will be there. So now the big question is, would you do MRI in this girl?
So definitely, she has she is presenting with a headache, and if she has other neurological, we should go for them.
Yes, so it's a difficult scenario. In a busy practice, you may say, okay, this is CDGP, let's wait. But the message is that if somebody is 16 years and still no development is not there, LH is just marginally elevated, think about a evaluation further. You carry forward.
So it's the same thing. If you go by the application, by definition, this girl definitely fits into the criteria where you would want to evaluate her for delayed puberty. The initial screening was normal, FSH was not high, so here we're not thinking of Turner syndrome. Prolactin was in the normal range and she had headache. So if you go by this, the app gives us an interpretation that this may be a permanent HH. Go for an MRI.
But if we do not go into that history, it will probably say that this will be a scenario in which it will go more towards LH level. And if your LH is like 0.4 or something, it may say CDGP. So that brings a very, very important pointer that you have to think of neurological features. That is the major message, I think, in the beginning of this case. Yeah. So carry forward.
The lesion was hyperintense for T2 imaging with focal areas of T2 hyperintensity instead of calcification. It was anteriorly abutting the optic chiasma and posteriorly abutting the interpedicular system. The pituitary gland was separately visualized with the above described lesion. So the treating pediatrician went ahead with an ophthalmic.
So now, if you look at this sort of a picture, I know this is very, very characteristic, but often there is confusion, as we always say, supracellular lesion, which is coming from above and coming down, and a cellular lesion, which is going up. Now, what are the key pointers that this suggests that this is a purely non-cellular lesion, clinically, investigation-wise, and this imaging?
So, cellular lesion, they will usually also have a supracellular lesion may have hyperlactin levels. When it descends down, it may cause anterior pituitary function defects, and in cellular, they may be present upfront. So the endocrine deficiencies may be present upfront.
So the chances of having endocrine deficiencies will be lower in somebody who has a supracellular mass to begin with. Deficiencies will happen when you have surgical intervention, which is done. Similarly, the other thing is that that your prolactin, as you said, if prolactin was high, it will more suggest towards a stalk compression. The LH-FSH levels, what do you think? So both scenario, if it is causing obstruction, they will be low. But one important pointer on imaging is suggesting that this is purely a supracellular lesion.
So a figure of 8 appearance.
Anything else which is there in this MRI that you have mentioned? Pituitary is separate. So if normally we say, even if you see a rim of pituitary around the lesion, that itself is a separate thing. But here it is classically, this is not there. So now if we talk about a girl who is 16 years old, who definitely has had this lesion, not now, for quite some time. This has to be there because the puberty has happened maybe few years, a large lesion with this sort of a pattern with calcification. I think there is no differential in terms of that. So this will be a craniopharyngioma, which is classically there in that. Yeah. Carry forward.
She was shown to an ophthalmologist, especially So like Sir has said that a 16-year-old girl presenting with delayed puberty who has a pre-puberty development on examination with a normal height, normal vision examination. With this classical MRI image, there is no other differential that comes to my mind like that.
Now, once we diagnose, the challenge starts from there as to how do we manage. And the management, of course, comes in the neurosurgical domain, but there is a lot of endocrine issues also, which are there both pre-operative, perioperative, and post-operative. So we will now have a discussion in that perspective. And if we now look at from there, Dr. Vibha will basically be talking about how do we do a perioperative care in this scenario.
So after the confirmation of the diagnosis, both clinically and the radiologically, the next part is the management. So as all the endocrine status of the patient, if already done, it is necessary to assess the endocrine status just before the surgery. So as the cortisol plays a very important role in the during the surgery, so we should assess the cortisol axis and get the cortisol 8 AM and ACTH stimulation test to see whether the axis is working or suppressed. And if the level is less than 140 at 8 a.m. and the ECTF stimulation test shows the level less than 550, we should start the hydrocortisone dose with the physiological dose, that is the 8 to 10 milligram per meter square per day. But as sir has already mentioned that the endocrine deficiencies mostly occur after the post-operative cases, but in some cases they could present pre-operatively also. So after the assessment of the cortisol, we should also assess the thyroid axis, get the free T4 and the TSH level. And if the TSH is less than 20 and the free T4 is low, we should replace the thyroxine also, but it should be replaced after 14 days of starting the hydrocortisone. And as these patients are more prone to have the growth hormone deficiency, assess the growth hormone deficiency as well by the growth hormone stimulation test. And if the growth hormone levels is less than 7 or 5 nanogram per ml, the deficiency will be evaluated. And as this patient has presented to us with a delayed puberty, so some patients will present to us with, preoperatively also. So get the LH, FSH, estrogen, and testosterone before the surgery. Arginine vasopressin assessment is very important because, as Dhani has mentioned, like 1 to 2% of the cases can also present DI in the preoperative phase. And so get the serum electrolytes, urine and plasma osmolarity, and if it shows the criteria fits into the diabetes insipidus, that this diabetes insipidus should be settled before the surgery by giving the low dose of oral desmopressin, starting from the 0.1 milligram at night, and you can increase the dose as required. So after getting the endocrine status assessment, we should do the visual assessment because this will provide the information about the extension of the tumor. So we should do the visual acuity by the Snellen chart and assess the visual field, identify if there is any bitemporal hemianopia, any scotoma present, assess the color blindness by the Ishihara chart, and get the fundus examination done for the papilla edema and the optic disc atrophy. So after the preoperative assessment, the next part comes in the surgeon domain. They have to decide which surgery should be chosen for it. And for this, the preoperative MRI is taken as a criteria for deciding the approach on the basis of hypothalamic involvement. So they have used the grading system, and the grade 0 is when the tumor is located in the subdiaphragmatic space and it has not involved the hypothalamus and there is no contact with the floor of the third ventricle. In the grade 0, the preferred approach is the transsphenoidal approach. And in the grade 1, as you can see in the MRI, the tumor is pressing and is in contact with the hypothalamus anterior to the mammillary body. It is arising from the stalk or the infundibulum or extended to the sella turcica, or it may extend to the base of the floor of the third ventricle. Here the preferred approach is the transcranial. In the grade 2, when the tumor has invaded all over the hypothalamus, in this it causes destruction and compression of the hypothalamus. Here the preferred approach is transcranial.
So what about this case, Dhani? Where was this grade 2?
So this was of my transcranial. There are two ways in the transcranial. One is
In terms of the imaging, which one will it fit?
She actually comes in the grade 0, sir, actually.
Grade 0. So she is not having contact with the floor of ventricle. So this could have been thought of a transsphenoidal, but the surgeon choice was about transcranial. There was no destruction of hypothalamus, nothing like that.
No, sir.
Okay. So in transcranial, which approach was followed?
The terminal approach was followed, which is the subfrontal.
So after the decision of the surgery has been made, the next step comes the perioperative management, which is very important, and it also comes in our domain as well as in the anesthesia people. So if the patient has symptoms of adrenal insufficiency, in those patients, the stress dosing should be started for 48 hours. Hydrocort should be given with a dose of 50 milligram per meter square, right 30 to 60 minutes before induction. And stress dosing should be given for next 48 hours with IV continuous infusion of 100 milligram per meter square per day. And it should be tapered in the next 48 hours to 50 milligram per meter square per day. And if the diabetes insipidus has been diagnosed in the preoperative phase, the patient should be asked to skip the night dose just before the surgery. Now, coming to the fluid management in the patient who has previously diagnosed as the diabetes insipidus, they should be given two-thirds of the maintenance with half DNS, and the KCL should be added and replace the insensible losses. And sodium levels, urine and plasma osmolality should be monitored hourly, and replace the urine output if it is greater than the sum of maintenance plus the insensible losses.
Major challenge, of course, is with regard to the fluid management, especially about
Yes, hyponatremia.
So, as you said, that they are basically talking about managing that you stop the DDNP.
Yes, right.
Why do you think they stop it?
Sir, because we are giving a fluid, because during the surgery, a lot of fluid has to be given, and if they will, patient has already taken that, it will cause the hyponatremia.
This is big problem. So, in terms of surgery, if you talk about surgical management, what they routinely do is that they will give a lot of fluids. So, you can't have an antidialysis going on, and that can cause the problem. They give a lot of steroids. So, usually this adrenal problem doesn't come at that point of time. So usually they will give dexamethasone or whatever which will cover on that. So that is not a big problem, that happens a bit later. But the main is about sodium and other changes which happen.
Okay, sir. So during the intraoperative management, generally the surgery is elective, but in the cases where there is a raised intracranial pressure and in the signs of vision loss, emergency surgery is done. And the surgical decompression is done, where the cystic components intracystic catheter is placed or the Omeyer reservoir is placed, from where the repeated CSF is aspirated to reduce the intracranial pressure. And via this intracystic catheter, after the surgery, the radioactive isotopes is instilled to reduce the size of the tumor in the postoperative period. But in the case where the surgery is elective, the amount of resection is decided whether depend on the size of the tumor. If the size is greater than 4 centimeter, and if there is a hypothalamic involvement, and if there is hydrocephalus, the resection should be limited and radiotherapy should be preferred. But if the size is less than 4 centimeter and there is no hypothalamic involvement, as in this case, the gross total resection is preferred. And in this case, the gross total resection was done.
It was only around 2 centimeters.
2 centimeters.
There is no hydrocephalus, there is no other problem. But now there is an increasing concern that probably radiotherapy may be used in more number of patients because it's immediately going to come back. So that is one option which is there. But otherwise, as you said, we can consider it, but they have not advised radiotherapy right away.
During the intraoperative period, in patients where the diabetes insipidus is not been diagnosed preoperatively, it can occur during the surgery also. If the patient has started passing a lot of urine, and if it is urine output is greater than 4 ml per kg per hour, and the serum sodium is greater than 145, and the serum osmolality is greater than 300, and urine osmolality is less than 300, and the presence of polyuria is persisted for greater than 30 minutes, and if no mannitol furosemide is given and there is no hypoglycemia, considered it as to be the initiation of the diabetes insipidus during the intraoperative period. So for this, we should not change the urine output with fluid. You should only correct the fluid deficit and blood loss with the normal saline and the blood products. And the fluid that should be given should be 2/3 of the maintenance only. Serum sodium, serum osmolality should be monitored hourly. And in case in some cases where required, vasopressin infusion can be given starting with the low dose 0.05 milliunit per kg per hour to 1 milliunit per kg per hour, with targeting the urine output to be less than 2 ml per kg per hour. Now, the main complication comes in the post-operative management, and it is well known that after the neurosurgical surgery. So we should monitor electrolytes, weight, and hydration and urine output hourly. So during the after the surgery, the central diabetes insipidus is the most common complication, and it generally follows the triple. It comes in the triple phase. It is not essential that triple phase response is present in all the patients. Some patient will show only the polyuric and the oliguric phase. Some patient can show all the polyuric, oliguric, and again the polyuric phase.
So basically what you're saying is that the triphasic response is that in the initial phase there is cell swelling. That is why you have DI. Then you have got release of ABP, which causes SIDH, and then you have got complete destruction causing a DI. So this process is not universal. So many patients may just have DI, which is permanent. Some people may directly have SIDH and then DI.
Yeah.
So there are variations which are there. So this is one of the classical triphasic which you try to explain on that.
Yes. So for the management, so if the patient is presenting with hyponatremia and polyuria within 24 to 48 hours, it is not always the central diabetes insipidus. It could be due to the saline overload during surgery, or it could be due to the transient central insipidus. The differentiation between the two is important because the treatment is different. So the criteria for the diabetes insipidus should be met to if the urine osmolality is less and the serum osmolality increases. But in case where there is a salt overload, the fluid status, there will be hypovolemia, the urine output will be increased, serum sodium will also be increased, but urine osmolality in comparison with the diabetes insipidus will be high. So in that case, you have to decrease the fluid rate, and if it is diabetes insipidus, you have to give the fluid.
So this is very common because neurosurgically they will give a lot of fluids. So often you will be asked, okay, this polyuria is there, and we give immediately because that. So method would be that first check the urinary osmolality. Because unless you document low urinary osmolality with a high sodium, you can't say it is DI. So that will cause more problem. If you give, you already have more fluid, you have given ABP, that will cause fluid retention.
So now coming to the management of the diabetes insipidus, we have two options. Either we can follow the fluid only therapy or restricted the fluid with the ABP. The preferred one is to give restricted fluid with the ABP. So if we are following the fluid only therapy, give the 40 ml per meter square per hour fluid N/4 with D5% dextrose, and replace the urine output with dextrose 5% if the urine output is above the 40 ml per meter per hour, and the fluid should not exceed, the total fluid should not exceed the 20 ml per meter per square. But the risk of this fluid only therapy is the dehydration and the hyponatremia. And if we follow the restricted fluid with the AVP therapy, the fluid that has to be given is 40 ml per hour per 40 ml per meter square per hour normal saline, and the urine output should not be replaced, and the total fluid should be only 40 ml per meter per square, but the risk factor is hyponatremia. Here the dose of the AVP should be 0.05 meters milliunit per kg per hour to 1 milliunit per kg per hour.
So basically the main message here is that is that you need to be cautious. If you are giving AVP, you have to give it the lowest dose. Now, what you want to achieve is a major fluid.
Yes.
There are two options. One is that you let loose everything and you keep on giving more. The problem there is that suppose the urine output is 8 liters per day or 10 liters per day, then you will be chasing it all the time. The child will become dehydrated. If you give too much 5% dextrose, what will happen?
Hyperglycemia.
What will hyperglycemia do? It will again
osmotic diuresis.
Again the same cycle will come up. So that is the extreme problem. The extreme problem here would be that he was in the DI phase, then you started and then went into SIADH. So if you're giving ABP, that will cause a problem. So a balanced solution will be the requirement is 1.5 to 5 milliunit per kg per hour of ABP infusion. So start with 0.5 or 1 and then gradually try to build up to make a controlled diuresis. You don't want to go into complete oliguria, you want to have a controlled diuresis so that you have got a good urine output which you can chase without causing hyperglycemia. So this will be a better approach in that perspective.
And for the management of the SIDA, which comes after this transient central diabetes insipidus, IV fluid should be stopped as soon as the patient is able to drink. But if the patient is not able to drink and the fluid has to be given, it should be very restricted fluid, and you should only replace the insensible losses, that is the 300 ml per meter per square with the half DNS solution. If there is a symptomatic severe hyponatremia, 3% saline should be given in infusion with a dose of 1 to 2 ml per kg per hour only for 2 to 3 hours.
We have seen patients with these serous surgeries who develop a severe hyponatremia because of the ABP. Now, if you give an infusion, how much should the sodium rise if you give an infusion?
So with the...
Let's say you're giving 1 ml per kg per hour, how much do you expect the sodium to increase in 1 hour?
1.5.
So we have used like 0.5 to 1 up to few hours also. Suppose somebody was 140 and suddenly is landed up around 110. In an acute setting, you can build it up on a more faster rate. So maybe 0.5 to 1 ml per kg per hour infusion is also required.
Yes.
Especially if somebody has given DDAVP or somebody has given a lot of vasopressin, that causes a problem.
And the overcorrection should be avoided, and the correction should be less than 10 to 12 millimole in the first 24 hours. So there has already been a struggle between the management of the diabetes insipidus and SIDH. The problems gets worsened by the cerebral salt wasting, which is due to the release of brain natriuretic peptide and the inhibition of the sympathetic activity. It also presents just like SIDH with hyponatremia and the high urine sodium. So it is important to differentiate between the cerebral salt wasting and the SIDH, as both present with low serum sodium, high urine sodium, and the high urine osmolality, because the treatment is totally different in these two entities. So if there is the urine output is decreased and it is SIDH, and if it is increased, it is salt wasting, and if the fluid status is showing hypovolemia, it is going towards the salt wasting, and if it is euvolemia, it is pointing towards the SIDH. From the treatment point of view, in the SIDH, we have to restrict the fluid, and in the salt wasting, we have to give the fludrocortisone with a dose of 0.05 to 0.1 milligram per day.
And uric acid, as we always discussed, is a very good way to move forward in terms of differentiating fluid excess, where uric acid level will be less, and fluid deficiency, where uric acid will be high,
more,
indicating a CSW, salt wasting.
So if I summarize the post-operative management, if you have to write the prescription for the fluid management just after the post neurosurgery, just give the half DNS solution with 2/3 maintenance with the replacement of the insensible losses, that is the 300 ml per meter square plus the urine output, and monitoring for urine sodium, urine output, and the electrolytes, and then decide whether the sodium is above 150 or it is between 135 to 50 or it is less than 130. If it is 150, see the urine osmolality, and if urine osmolality is greater than 800 milliosmol, if there is a hypovolemia, we have to increase the fluid rate. But if the urine osmolality is less than 800 milliosmol, then it is pointing towards the DI. We should give the fluid, a restricted fluid with the ABP. If the sodium is between the 135 to 150, we should continue the same fluid replacement. If the sodium is less than 130, we should check the volume status. If there is a dehydration, this is pointing towards the salt wasting. And if it is eubulimia and hypovolemia, it is pointing toward the SIDH. For the salt wasting, give the NSAID and fludrocortisone, and for the SIDH, do the fluid restriction. Salt wasting is a transient phenomenon. It generally resolves by 3 to 4 weeks. But in some cases, the salt wasting develops along with the DI. And these patients, even on AVP, they present with polyuria. So polyuria in these patients should not be considered as an uncontrolled DI. It is generally due to the loss of sodium in the urine. So higher doses of APP should be avoided in these patients and managed with fluids and salt replacement. Hypothalamic dipsic diabetes insipidus is found after post-surgery of the craniopharyngioma. So the patient should be asked to take water regularly. And after this, the long-term follow-up for the hormone replacement, hypothalamic obesity and sleep disorders should be done.
The other thing, of course, is that if you have adipsia, you will develop severe hypernatremia. So you have to be cautious in that scenario, and that is the scenario in which you can develop hypernatremia.
So moving on to the management in the index case, for her periopharyngioma, a gross total resection was done by right pterional approach, and the histopath was suggestive of histopath showed an adamantinomatous craniopharyngioma, which was in sync with our clinical diagnosis. Moving on to the anterior pituitary functions. So we know that the pre-op values had shown a subclinical hypothyroidism with normal cortisol levels. However, function done in the post-op period, about 3 days post-op, showed low FT4, low TSH, and low cortisol levels. Thus, diagnosis of MPHD was made here. So for MPHD, she was started on hydrocortisone followed by thyroxine. Looking at the posterior pituitary functions, so just immediate pre-op, her sodium potassium were in the normal range. In the 2 to 3 days post-op period, the child was found to have polyuria with a dilute urine on urine routine exam, low urine specific gravity. Thus, a temporal relation of surgery with polyuria and in presence of sodium hypernatremia, a possibility of DI was considered here in this case, and vasopressin was started, although no urine osmolality was done in this child. She was started on vasopressin, on which her sodium levels began improving. She went on to go to the hyponatremic side. Thus, vasopressin was tapered and stopped here. Cortisol and thyroid profiles were done and they were found to be in the low range, for which hydrocortisone was started. Upon starting hydrocortisone, within 10 days of starting hydrocortisone, the child again developed polyuria and there was unmasking of DI here in this case.
So I think this is again a message that we always say, if you start on hydrocortisone, you expect DI to happen. So this is what again was happening.
So this R index child had shown a triphasic response of DI, SIDH, and DI again. So for DI, desmopressin was started here. So as we've seen, we've managed the craniopharyngioma part, we've managed the anterior and posterior pituitary deficiencies that this child had. What remains next is that we monitor her for hypothalamic complications, and although she did not have anything at the current visit, but this is definitely something that we should be monitoring her growth. Pubertal induction is something that will come up next in this curve.
I think the big thing here was that this probably came up at the right time, because she did not grow to a big lesion and the site was also good. So I think this was an interesting case in which we focused a lot of discussion about pre and post-operative evaluation. Dr. Priska is asking, please explain why if morning cortisol is normal and ECG stimulation test must be done. So if your morning cortisol is very high, in the sense that if it's above a supranormal range, then you can avoid it. But before you go for surgery, maybe a ECG stimulation test will definitely be of help in that scenario. Dr. Bharani is asking, craniopharyngioma is a growth without GH state. How decide the need for GH supplements? Definitely, this is a very, very important question that Dr. Bharani has put in, that as discussed, because of the insulin resistance due to obesity, they will grow in the initial 1 or 2 years. Now, what we usually see is that after that, the growth velocity really falters down. And in that scenario, often you can do a IGF-1 level, which will be low. Now, in this scenario, you already have a multiple pituitary hormone deficiency If the IGF-1 is low, you can diagnose growth hormone deficiency then and there. You don't need to do a growth hormone stimulation test. So it will largely be clinical. So anyway, 1 year, we don't need to treat. We will wait and watch. And usually by 2 to 3 years, we had that scenario. The boy who was coming the other time also, in which they were initially, he was tall, and then suddenly his growth became zero. And then we had to give growth hormone, pubertal induction. You can all go and have a look at our website where we have got resources like this and the courses and the mobile application. You can all go and have a look at our website, our courses which are available, and the mobile application. So